actually the chair of cardiovascular diseases here at Houston Methodist Sugarland Hospital, and I am also the director of our chest pain center. And I'm in our physician organization where we have approximately 9 members. So I'm going to go ahead and get started here. So contrast-induced nephropathy, or AKI related to contrast. So there are 3 criteria that we use to make this diagnosis. So it's defined as an iatrogenic disorder with an absolute increase in the creatinine of 0.5 milligrams per deciliter, or a relative increase in 25% of the serum creatinine following the exposure to contrast compared to baseline. We usually see this within 24 to 48 hours of contrast exposure, with the peak serum creatinine occurring in approximately 3 to 5 days. And other alternative explanations for renal impairment have been excluded. This slide goes over the calculation of the creatinine clearance that we use here at Houston Methodist Sugarland Hospital, along with the stages of chronic kidney disease. So of course, stage 1, or under normal circumstances, the GFR of over 90, mildly decreased GFRs from 60 to 89 milliliters per minute. Mild to moderate decrease is 45 to 59. Moderate to severe is 30 to 44 milliliters per minute. Severely decreases from 15 to 29 milliliters per minute, and renal failure is considered less than 15. And so, our focus is really on the mild decrease, or stage G2 or below. The etiology of contrast-induced nephropathy rests on really 3 areas here: the type of contrast that one uses, definitely the contrast volume, and the risk factors. So the epidemiology. So approximately 1 to 6% of the general population would experience contrast-induced nephropathy when exposed. This can be up to approximately 50% in certain high-risk populations that we will talk about. Among patients with diabetes with mild to moderate chronic kidney disease, you can see it in 9 to 40%. In those patients with severe chronic kidney disease, it may be seen in 50 to 90%. Cases of chronic contrast-induced nephropathy leading to dialysis are approximately 0.5%, and it is the 3rd leading cause of hospital-acquired acute kidney injury. So it's behind episodes of hypotension leading to ATN and also surgery-related renal failure. Now, this slide illustrates some of the more prevalent risk score models for evaluating contrast-induced acute kidney injury. So to the far left is the Marin risk score, and that's the most popular score, one that we utilize. The one in the middle of the screen is the NCDR risk score, and then to the right, we have a PCI risk calculator, which is also rarely used. Now, this slide just goes into a little bit more depth regarding the Marin risk score. And so basically the way this score works, it looks at various risk factors. So whether or not the person has hypotension, the presence or absence of an intra-aortic balloon pump, congestive heart failure, the person's age if they're over 75, the presence or absence of anemia or diabetes, the contrast volume, and the baseline serum creatinine. And based on that particular score, you can determine the risk of contrast-induced nephropathy and the risk of dialysis on an individual basis. Contrast, as you know, is definitely harmful to the kidneys. And the way the pathophysiology presents itself is that the contrast can lead to a transient reduction in renal blood flow. The iodine is also cytotoxic to renal tubular cells. It leads to the attack of adjacent cells by free radicals and results in an increase in the serum creatinine. So, contrast basically damages the tubular lumina of the kidneys and results in AKI through that mechanism. Contrast definitely increases the risk of dialysis. There is a higher risk of heart disease. Acute kidney injury increases the risk of in-hospital mortality, which leads to longer hospitalizations, 30-day readmissions, and progression of chronic kidney disease. This slide here looks at how acute kidney injury increases readmissions in patients with chronic kidney disease. So at 30 days, you can see approximately a 50% relative increase in readmissions. Over 90 days, it's approximately a 28% relative increase in admissions. AKI also increases mortality in our patients with chronic kidney disease. So there's a 167% relative increase in in-hospital mortality at 30 days and 117% relative increase in in-hospital mortality at 90 days based on this current study. There are no known treatments for acute kidney injury. The only solution is to try to prevent it from happening in the first place. And we're going to go over various strategies which will help you with that. This slide illustrates how the NCDR tracks acute kidney injury. It's a quality indicator for the Cath Lab. As you can see, the 50th percentile is approximately a 6.14% incidence. And you definitely want to be to the right of that 50th percentile, ideally within the 90th percentile, but as low as reasonably achievable. So clinical guidelines for acute kidney injury prevention. So you definitely want to screen for the risk of acute kidney injury. So that would be in your patients with a GFR of less than 60. You'd like to increase hydration. So patients at risk should receive adequate hydration, especially before the procedure and afterwards, and hydration protocols should be in place. And contrast should be minimized. There should be threshold volumes set. So this is a AKI prevention, screen for risk and the impact of various comorbidities. You definitely want to try to keep your contrast load under 75 mLs. Each 75 ml increment dramatically increases the risk of acute kidney injury. The person's age needs to be taken into account. The presence or absence of diabetes, existing chronic kidney disease, whether or not the patient is in shock, and also the presence or absence of severe kidney disease. So across this spectrum, the presence of these risk factors dramatically increases the risk of acute kidney injury. This slide illustrates some various nephrotoxic agents that one should be mindful of. So the ACE inhibitors or ARBs can decrease intraglomerular pressure and can augment the damage induced by contrast. So prior to administering contrast, one should consider holding ACE inhibitors or ARBs. Other drug classes which can affect or cause a worsening of contrast-induced nephropathy would be the non-steroidal anti-inflammatory agents, certain antibiotics such as aminoglycosides and antifungal agents, the antiretrovirals, certain immunosuppressants, and also certain anti-neoplastic agents. So you want to be mindful of those. Now we're going to talk about certain procedural and medication related principles which may result in a reduction of acute kidney injury related to contrast. So there's a study looking at radial artery access. So this study was published in 2018, and it basically showed that patients who underwent coronary angiography via the radial approach had a lower incidence of acute kidney injury related to contrast. So this is definitely something to keep in mind. Also, there's another study looking at the use of statins, and also patients that were treated with rosuvastatin 40 milligrams followed by 20 milligram daily dose were shown to have a reduction in contrast-induced acute kidney injury. There also have been evaluated N-acetylcysteine. Now, in the past, we had used that, but there is a study out, a randomized study looking at that. So N-acetylcysteine has not been shown to be beneficial. So we don't usually use that on a regular basis. Sodium bicarbonate is a reasonable, along with normal saline, are very reasonable hydration for patients in an effort to prevent acute kidney injury. This slide illustrates some hydration protocols that are in use. Some of the ones that we use in particular are listed here, the pre-procedural and intra and post-procedural hydration protocols. So taking into account the patient's weight, we administer half normal saline or normal saline hydration approximately 3 to 12 hours before the procedure and up to 6 to 12 hours after the procedure. And this is done on every patient. So this slide looks at low consistency in contrast delivered to patients. So this looks at acute kidney rates and contrast volumes that vary among various users. So as I mentioned earlier, every 75 milliliter incremental use of contrast results in increased use of acute kidney injury by 42%. So this is something to definitely keep in mind. In the Cath Lab, attempting to try to standardize and reduce contrast volume usage among operators can be a challenge, but this looks at the variation of contrast used among operators. Contrast volume does matter. So this slide looks at the ratio of contrast volume to the creatinine clearance. And as you can see, as you move to the right of this graph, as that ratio increases, the incidence of contrast-induced nephropathy increases incrementally. So definitely trying to keep that contrast volume to a minimum will help prevent contrast-induced acute kidney injury. This slide here also just reiterates the previous slide, looking at the GERM ratio, the contrast volume to the creatinine clearance, and just further illustrates that the more contrast you use, the more likely acute kidney injury is to occur. So reducing contrast delivered to patients prevents acute kidney injury. So the Divert system is the only FDA-cleared, clinically proven technology to reduce dye or contrast delivered to patients during angiographic procedures. There's no compromise in image quality. It allows for real-time contrast monitoring and precise measurement of total contrast dose delivered to the patient. And it allows you to customize maximal allowable doses by individual patient. Now, I find that many of our patients really like the Divert because it really provides some objectivity to what we're doing in the Cath Lab. So, in the absence of the Divert, we don't always have a printout or absolute data regarding the volume of contrast that we should be giving, and also the exact limits, and also what we have given. So for some of our patients with chronic kidney disease, they are very in tune to the potential harmful effects of contrast. So many of them are very reassured when we use the Divert, and we're able to tell them beforehand that we have certain thresholds of contrast that we plan to use, and we can demonstrate that to them following the procedure. So the Divert has resulted in a 40% average dye reduction delivered to the patient and a demonstrated AKI reduction. Okay, the Divert system integrates into a standard procedure manifold, and we're going to see a video on this shortly. Minimal time to set up, no change in standard injection procedures, and it's a single-use system. And I use this on all of my patients. And again, you can customize contrast delivery to kidney function. So, based on a person's threshold for the contrast use, you can adjust the Divert to accommodate for that. Right. So AKI prevention strategies proven successful in real-world hospital settings. So you can see this slide illustrates that at various institutions, There have been a significant reduction in AKI using these strategies. Our hospital saw a 35% overall reduction in AKI. Okay. So we're going to talk about, our personal experience. And so how did we initially become aware of increased contrast-induced nephropathy? And I would say that really the review of the NCDR data is really what got our attention. Before, or if you don't have this, there's quite a bit of subjectivity that may go into various complications or what have you in the Cath Lab. But the NCDR database really allows you to compare your institution to other institutions. And it was based on this data analysis that contrast-induced nephropathy came to our attention. What did we do about it? So we decided to set up a protocol that involves screening patients at risk for contrast-induced nephropathy, which included people with the creatinine clearance or GFR of less than 60. We instituted a hydration protocol before the procedure, which we talked about, and patients at risk were flagged going into the Cath Lab. We also instituted, in addition to our timeouts that we were already giving, that a contrast recommended threshold of 2 times the GFR and a maximum dose of 3 times the GFR. So when we go to perform a catheterization, before anything is performed, the creatinine clearance is discussed and the contrast limits are discussed on each patient. And many of our colleagues are using Divert to help reach those goals. We also announced contrast use during the procedure, and we also have a post-procedure hydration protocol. This slide illustrates the reduction that we saw initially from around 2015 through 2017, a reduction in AKI. Through 2019 and 2020, we have data showing that our rates have ranged anywhere from 3 to about 6. So we're able to maintain a reduction in AKI that is usually below the 50th percentile. What were the challenges? So, some of the challenges that we faced, in terms of recognizing and treating contrast-induced nephropathy, I think the biggest challenge is identifying it at your institution. So, definitely reviewing the NCDR data and various parameters such as that, so that you're aware that it exists, I think is important. Also, trying to make your colleagues aware of that and the importance of paying attention to contrast-induced nephropathy, and the amount of contrast you use would be a challenge. And also, anytime you introduce any new initiative into the hospital or any setting such as this, it always introduces some potential challenges. And you basically have to, win over and convince your colleagues that, what you're implementing will be helpful to patients. And most people are on board with that once they realize it. What are some of the future directions? Some of the future directions that I see are that, with possibly each patient, we're able to, give more comprehensive information on their risk of contrast-induced nephropathy before the case, better documentation of contrast use and limits during the case. And I'd actually like to see a printout on each patient of the contrast limits and the contrast used, so that patients can know that we're working feverishly to try to prevent any complication related to contrast. Other future directions would be more utilization of imaging such as IVUS during the procedures to help reduce the use of contrast. During some of our PCIs, doctors take extra puffs, just to look at the stent and make sure the stent is well opposed. And, maybe as opposed to taking extra injections, using an IVUS or OCT to look at the stent could help reduce utilization of contrast. So I have a case here that I'd like to discuss. So this is a patient, JR, a 91-year-old female with a history of a pacemaker who came to see us with chest pain and an end-stemming. She was hemodynamically stable at the time of her evaluation. Her creatinine clearance was 30, and her hemoglobin was 11.2. And based on her Marin risk score, it was 11, and that translated into approximately 21.6% risk of contrast-induced nephropathy and approximately a 1% risk of dialysis. So in this particular case, nephrology was consulted and we implemented the hydration protocol. And the recommended contrast dose was 60 milliliters, and the max dose was considered 90 milliliters. And we used a divert in this case. And so procedural considerations, we're going to consider using a radial approach. As I mentioned earlier, it's been shown to reduce the risk of contrast-induced nephropathy. Other consideration was the use of a 4 French catheter, resulting in less contrast being injected. Also, whether or not we needed to do a left ventriculogram. We had an echocardiogram, and we didn't necessarily need to use that. This is an angiogram done by the left radial approach. And as you can see, this is a 4 French catheter, and we've gotten very satisfactory visualization. So you have the left circumflex here and the LAD. Here's another view, the left circumflex, LAD, mild to moderate atherosclerosis. Here, a nice view of the LAD. We also have a view of the right coronary artery and no significant stenosis there. So, through the use of Divert and a 4 French catheter, we were able to do this case with approximately 29 cc's of contrast, and the patient tolerated the procedure well and really did not have any complications related to that.